call our meeting to order. Welcome everybody to meeting number 84 of the Standing Committee on Health. Today we are going to have a study of the supplementary estimates, and we welcome our Minister of Health, the Honorable Jeanette Petitpas-Taylor, here today to join us. And I see in your notes, Madam Minister, that you're going to introduce your colleagues beside you, so I'm going to leave that to you. Normally I introduce them, but so if you would open up with a statement of 10 minutes, we'd appreciate your comments, then we'll go to questions.
Well, thank you very much, Mr. Chair, and thank you for inviting me today to present the Health Portfolio Financial Overview of Supplementary Estimates B for the period of 2017-2018. And I am thrilled to be accompanied today by my Deputy Minister, Simon Kennedy, Dr. Teresa Tam, who's our Chief Public Health Officer, Carolina Gilberti, Executive Vice President of Canadian Food Inspection Agency, Yves Bacon, the Vice President and CFO Corporate Management Branch of the Canadian Food Inspection Agency, and Michel Perron, the Executive Vice President for the Canadian Institute of Health Research. We
are pleased to have the opportunity to discuss the resources that we are requesting to maintain and improve the health needs of all Canadians.
Continues to deliver on several priority initiatives for our government. In these supplementary estimates B, the health portfolio's budget will increase by just over $297 million, raising its proposed authorities to date to $7.16 billion. This constitutes an increase of approximately 6% over our authorities to date. This funding will allow the health portfolio to achieve several key objectives in several priority areas, which I will now briefly address.
Our government recognizes that Canadians expect the healthcare system to adapt to their changing needs. They also expect federal, provincial, and territorial governments to work together to strengthen our healthcare system. In August, the Government of Canada and the provinces and territories agreed to a common statement of principles on shared health priorities. This common statement of principles outlines key priorities for federal investments in mental health and in addictions, as well as home, palliative, and community care. It commits governments to work with the Canadian Institute for Health Information on a set of common indicators to measure progress in these areas. And it reaffirms a shared federal, provincial, and territorial commitment to improve the affordability, accessibility, and appropriate use of prescription drugs. Every province and territory has also agreed to its share of $11 billion over 10 years in federal funding for home care and mental health. They have also agreed to the broader funding arrangements under the Canada Health Transfer, which will provide more than $200 million in federal health funding over the next 5 years. Health Canada is now in negotiations with each province and territory to develop multi-year bilateral agreements that will outline the terms and conditions for the remaining funding over 10 years.
Canada is committed to a renewed nation-to-nation relationship with Indigenous people. Part of that commitment involves ensuring that First Nations and Inuit have access to culturally appropriate health programs and services. On December, the Government of Canada announced the formal creation of the new Department of Indigenous Services Canada. This is truly an important step in the government's transformation of services to Indigenous peoples. By consolidating services into one department, we will be improving the sharing of information and strengthening our capacity to meet the needs of the people that we serve. Therefore, significant funding associated with Indigenous programming included in these supplementary estimates will now fall under the purview of Minister Philpott. I truly remain committed to supporting our government's important goal of improving Indigenous health. Throughout this transition period, I will support my colleagues, Minister Bennett and Minister Philpott, to help ensure that First Nations and Inuit continue to have access to high-quality health services and programs. I will also work to ensure that we maintain effective relations with our Indigenous partners. Un autre dossier essentiel faisant
Another key file under the health portfolio is the legalization and regulation of cannabis. We know that the current approach to cannabis does not work. It has allowed organized crime to profit while failing to keep cannabis out of the hands of our young people. This is why our government introduced Bill C-45 to legalize and strictly regulate access to cannabis. In these estimates, we are requesting $39.1 million to develop, implement, and administer a federal framework to legalize and regulate cannabis. This will include the licensing and oversight of producers of cannabis for medical and non-medical purposes.
The health priority that we are addressing is the opioid crisis. We continue to use all the tools at our disposal to address the growing number of overdoses and deaths caused by opioids. As you know, there were more than 2,800 apparent opioid-related deaths in Canada in 2016, and the preliminary data for 2017 suggests that that number of opioid-related deaths will exceed 3,000. These estimates include an increase of $6.2 million to address the crisis. This includes funds to support increased access to harm reduction measures and to prevent infectious diseases that may result from sharing drug use equipment. This is a complex health and social issue, and it will not be fixed overnight. This is why our government will continue to work with our partners from across the country to take action on this public health crisis. En ce qui a trait à l'incidence des changements climatiques sur la
With respect to the impact of climate change on the health of Canadians, I am pleased that Budget 2017 allocated $47 million over 5 years to Health Canada, the Public Health Agency of Canada, and the Canadian Institutes of Health Research to address the health risks associated with the changing climate. The Public Health Agency of Canada recently accepted proposals for the Infectious Diseases and Climate Change Fund. These proposals will address gaps in knowledge related to climate-driven, foodborne, waterborne, and zoonotic infectious diseases in Canada. This includes preparing for and protecting Canadians from climate-driven infectious diseases, including Lyme disease and West Nile virus.
Committed to promoting and improving public health and increasing vaccination rates across the country. Vaccination remains one of the most effective public health tools to protect Canadians, which is why we are allocating $1 million in funding towards an advertising and public education campaign to help Canadians make informed decisions about vaccinations. Vaccines are effective and safe and play an important role in the protection of our health and of our communities. And I am pleased that our government, in partnership with provinces and territories, has endorsed new vaccination coverage goals and targets for reducing vaccine-preventable diseases by 2025. Ce budget supplémentaire des dépenses tient compte d'une augmentation.
These supplementary estimates reflect an increase of $7 million in the budget of the Canadian Food Inspection Agency, which will support the CFIA's important ongoing work in plant protection, animal health, and food safety. Safe food remains a top priority for the CFIA. While Canada already has one of the safest food safety systems in the world, our government is dedicated to improving that system so that Canadian families continue to have confidence in the food they eat. The CFIA has increased its focus on prevention, preparedness, and response to minimize risks to human, animal, and ecosystem health. This includes plant protection and animal health, the first links in the food chain. In conclusion, I am confident that the amounts noted in these estimates and the funds identified in Budget 2017 will allow the health portfolio to continue to support better health outcomes for all Canadians and to build a healthier country. Thank you again to the committee for inviting us to join you today. I am happy to take your questions now. Thank you.
You have 31 seconds left if you wanted to finish, but that's all right. Now we'll go to 7-minute rounds of questions with Dr. Alfson.
Thank you so much, Minister, for coming. We really appreciate you doing this today. Now, as you know, I'm a recovering emergency physician. I spent 20 years working in emergency departments, and public health, basically, any problem with public health, often came down on our departments first, and we would see trends. And among the trends that we would see was the detrimental health effects of people who couldn't afford their medications and becoming ill simply because of that. It's also, as you know, we're studying the structure and implementation of a national pharmacare program. One of the things we found is that we, as Canadians, we pay the second highest drug costs in the world. And as part of our, although the report's not out, we have a parliamentary budget office report that says that if we had a national pharmacare program, the nation would save roughly $4 billion a year. So could you share with us what steps you and Dr. Philpott before you have done has taken to reduce the cost of medications to Canadians?
Sure. Well, thank you very much, Dr. Doug. Thank you so much for your question. And it's certain that our government is committed to strengthening Canada's healthcare system, and that includes enhancing accessibility and affordability and the appropriate prescription drug use. And at the end of the day, that's absolutely a priority of our government. In Budget 2017, we were able to invest $140 million to lower drug prices and to improve access to prescription drugs and to support the appropriate use of medication. We also were able to join our provincial partners and territories, and we became members of the Pan-Canadian Pharmaceutical Alliance. And by becoming a member of the Pan-Canadian Pharmaceutical Alliance, we were able to actually do bulk buying when it came to prescriptions. And as a result, we've been able to save a significant amount of money with respect to the costs related to that. Also, as well, as I'm sure that you're aware because you've been doing some studies, we've certainly are in the process of modernizing the Patented Medicine Act, and all of that as well is certainly going to be very helpful in the work that needs to be done. When we look at the Patented Medicine Prices Review Board, modernizing it is not something that hasn't been done for many years, so it's certainly a step in the right direction, and again, looking forward to the continued work that's going to be done there. I'm also aware that your committee has done quite an in-depth research of this issue, and once again, I'm really looking forward to reviewing the recommendations brought forward by the committee, as I think we can certainly continue on our conversation. And finally, I'd like to say that in October, I had the privilege for the first time of having a meeting with my provincial and territorial health ministers, and the issue of drug prices certainly came up. And as provinces and territories and the Federal Health Department, we've certainly indicated that it's a priority of ours to improve access to medications, because we certainly recognize that Canadians pay way too much for drug prices, and that is certainly something that we want to address. Mm-hmm. But taking these steps to start off is certainly a step in the right direction.
Mm-hmm. All right, thank you very much. I've also noted the good work that's been done by the ministry regarding addressing the opioid crisis. Again, I keep coming back to what I was doing in my previous life, and it was something that I saw a lot of in that job, and sometimes with very tragic results that I had to witness. Now, I was very pleased that the government was able to pass C-37, which did increase the ability of community health groups to make safe consumption sites available, as we know that this is something that would save lives, and the initiatives to making naloxone more available, I think, has been a very important life-saving tool as well. So we undertook a study of the opioid crisis, and we've produced a report that had 38 recommendations. So would you be able to tell the committee what progress you've had in implementing that series of recommendations?
With respect to the work that we've done in the opioid crisis, first of all, as indicated in my opening statements, we recognize as a government and as all Canadians that we're faced with a public health crisis when it comes to the opioid situations. Again, today we've seen some numbers that have been released from Ontario, and the numbers are devastating. We recognize that they're not just numbers. These are people's children, their mothers, their fathers, their personal stories. And the damage that is created by these laws, the collateral damage is huge to families and to communities. So it's certainly an area of priority of mine as Minister of Health. I have to say that the first briefing that I received as Minister of Health was specifically on the opioid crisis, and it's my #1 priority that I'm dealing with on a regular basis, on a daily basis. So as you've indicated, some of the key steps that we've been able to take so far when it comes to Bill C-37, that was certainly an important step in the right direction in order to streamline the application process for the consumption sites that are out there. We certainly need to make sure that we have a harm reduction approach when it comes to dealing with these situations, and we are pleased to see the progress that has been made. When we formed government, we had one of these sites that was available in Canada, and now we have a total of 28 supervised consumption sites that are available. So those are certainly, again, steps in the right direction. Also, when you mention about making naloxone more readily available, ensuring that it's a non-prescribed medication certainly allows many individuals to have access to that tool, and that's exactly what it is, something that they need to effectively deal with the situation on the ground. Certain provinces make sure that that is available free of charge, but again, that's a decision that's brought forward by provinces and territories, but we certainly need to do all that we can to ensure that the naloxone product is more readily available. We've also made significant investments as well when it comes to addressing this situation. When the health accords were being negotiated last year, there's a few provinces that indicated that the opioid crisis was an absolute priority in the area that needed to be addressed. So above and beyond the monies that they received for the health transfers, if we look at the province of British Columbia, for example, they received $10 million in direct funding to deal with this crisis on the ground. If we look at the province of Alberta, they received, I believe it was $6 million to deal with it on the ground. And also Manitoba, there was a series of issues, targeted issues that they needed funding for, but opioids was certainly one of those as well that was listed. So they received additional funding as well. And aside from that, we also can't forget that Canadians as a whole have told us that mental health and addictions is absolutely a priority for them. And through our budgets in 2017 and with the healthcare agreements, we recognize that we've made significant investments, $6 billion in the area of mental health. So again, that certainly helps. There's steps in the right direction, but I can't say enough that we recognize that we cannot be complacent when it comes to this crisis. We have to continuously monitor the situation. We have to address the needs that are out there, and we have to be progressive. And also, we can't deal with this alone. There's no one single solution to this, and we recognize that we have to work with provinces and territories and frontline workers. That's going to be key.
All right, thank you very much.
Mr. Weber.
Thank you, Mr. Chair, and thank you, Minister, and your staff for being here today. Minister, you alluded in your presentation to the topic of Lyme disease briefly, and of course, after almost 6 months, this committee did finally just yesterday get your letter, your response on the Lyme disease investigation that we did here in committee. The response from you, Minister, is certainly not going very well in the Lyme community, and I'm not surprised. There are hundreds, if not thousands, as you know, Minister, of Canadians suffering daily from Lyme disease. And we know that there are likely many more that have been misdiagnosed or are not getting the treatments that they need. There has been conferences. We studied it here in committee. There have been experts that provided their opinions and recommendations, and we've had public consultations as well. Enough talking has happened, and now it seems that no action is really taking place. Without proper funding, nothing is going to happen. The government, of course, as you know, has set aside $4 million. So let me put that into perspective. We spent more on a hockey rink out on Parliament Hill than we are on this major public health issue. So why do you, Minister, believe that proper Lyme disease research can be done for less than the cost of putting up a patch of ice on Parliament Hill?
Well, once again, thank you for the question. I'm pleased to hear that you did receive my letter that was provided, I believe, late this week. first of all, I guess I have to take a step back. Our government certainly recognizes that Lyme disease is an emerging infectious disease in many parts of Canada. And I know coming from New Brunswick, there's certain hot spots that have been identified in our province alone. So we certainly, I'm certainly quite aware of it. And I'm also aware that the long-term impacts and the physical impacts on individuals that live with Lyme disease is tremendous. In my riding of Moncton, Riverview, and Dieppe, I had an opportunity to attend a support group last year because I received several emails from individuals that live with Lyme and suffer from Lyme disease. So I wanted to have an opportunity to meet these individuals and to actually hear their stories because I really didn't know a lot about the topic. And to hear those testimonies certainly, hit home for me. And I also recognize there's someone on your committee that, Ms. Ludwig, who's done a lot of work in the area of Lyme disease as well. So again, we certainly recognize the devastation impact that Lyme disease can have on families.
Do you think $4 million, Minister, is adequate? Is $4 million adequate funding for this disease?
To address your question that you had asked, with respect to the investments, as I'm sure you're very much aware, that in May 2017, we were able to release the federal framework.
Yes.
And the federal government's role, as I see it, there's really 3 pillars and 3 priority areas that we really have to lead as the federal government. When we look at the issue of surveillance, we recognize that we have to gather better data to get a clear picture of exactly what is going on and the magnitude of all of
we
this.
certainly understand that here on this committee.
The other thing as well that is another pillar that I believe is very important is the issue of education and awareness, because many Canadians perhaps are aware, but we also know that we have to provide more information with respect to detection and awareness, and the list goes on. And finally, another area that I believe we have a role to play as well is in the area of guidelines and best practices. So those are the key areas that we know that the federal government certainly wants to focus on. And with the investments that we've made with respect to the federal framework, it's certainly a beginning and a step in the right direction. I would perhaps like to ask Dr. Tam as well if you could perhaps provide a bit more information with respect to the work that's being done as well.
Well, we've been through this already. We've had a study on this, Minister, so thank you anyways. Perhaps you can answer my next question, Dr. Tam, and that's with my concern and many people's concern with the blood system and its safety. The Minister, you said in your letter that there is no evidence that Lyme disease can be transmitted through the blood supply. This is very different than saying science has proven that Lyme disease cannot be transmitted through the blood supply. It's like saying, I haven't seen it happen, so it can't happen. So I would like to know from Dr. Tam or you, Minister, what is being done to scientifically prove that Lyme disease cannot be transmitted through the blood supply? Can the Minister unequivocally state that it is impossible to get Lyme disease through the national blood supply?
Dr. Tam, would you mind taking that question, please?
And I believe the Canadian Blood Services has provided some of the response to this question as well. And so there's been no evidence to date of any Lyme disease in the blood supply. And while not every single blood donor is tested, the Canadian Blood Services screens people out who are sick. But they also do studies intermittently to look at the donor group, and they haven't found any evidence. But I also want to go back to the fact that we are investing together with the CIHR $4 million in research.
Yes.
And here are some of the questions that some of the investments in diagnostics, some of the investments in other areas of research will bring us more and more evolving information.
Do you believe that $4 million is adequate, not only for research, but now we've got surveillance, we've got the education, we've got the guidelines and best practices, that the 3 pillars that the Minister has mentioned? Is $4 million adequate? I don't believe it is.
So, well, certainly from the Public Health Agency, and I can probably say from the CIHR perspective, we really welcome the dedicated funding. That's the first time we received this, and we announced the $4 million for the research network. Now, on top of that, there is $3.7 million for other activities. So out of the $4 million, only part of it goes to the research. The rest goes to, very importantly, the education of frontline medical professionals and also patients. So that's one area it will be funded, but we are also leveraging the responsible parties like the health professional societies who do have a role to play, and also surveillance as well.
Yeah, I just, again, can't say enough how inadequate this funding is. It seems like there's more priority for a 150 celebration out on our front lawns here at Parliament Hill. Minister, I am sure that your office, like mine, is being inundated right now with emails from folks who are unhappy about there being an excise tax on medicinal marijuana. Now, these Canadians point out that no other prescription medication is subject to an excise tax. So my question, Minister, is why is this government taxing one prescription medication and not any others? And is it the government's intention to maintain this policy or bring medicinal marijuana's tax treatment in line with all other prescription medication?
Well, thank you for the question. As you're aware, the Health Committee worked very hard at studying Bill C-45, and you did tremendous work at the beginning of the summer, if my memory serves me well, but you were here well before we were all here, and heard from many witnesses over 5 days, 5 long days, I was told, but very interesting days. We also have to recognize the task force had met people from coast to coast to coast and provided some recommendations to government with respect to some areas that we should consider. With respect to the area of taxation, as you're very well aware, Minister Morneau is meeting with his provincial and territorial colleagues, I believe it's next week, and the issue of excise tax is certainly going to come up with the area of, with respect to where the profits are going to be going or the monies collected are going to be going. And that is a conversation that is ongoing with them as well. I don't know if my Deputy Minister wants to add anything to that.
Just very briefly, please.
You know, I think I would just, in terms of the Minister's comments, that the tax policy matters are generally the purview of the Finance Department. So in those areas, we defer to Finance. So that would be a good question, I think, to raise with colleagues from our Finance Ministry.
Thank you, Minister.
Right, time's up. Mr. Davies.
Being with us and to your staff. Minister, in 2009, the H1N1 flu virus caused 428 deaths in Canada. In response, the federal government mobilized an emergency operations center 24 hours a day, 7 days a week. This provided more than 6,000 person days of assistance to help coordinate emergency responses across the country. Now, in comparison, we have had 2,800 deaths in 2016 and 3,000 deaths this year from the opioid overdose crisis. And yet only 113 person days of assistance have been reported by the Public Health Agency of Canada, and that's to help write 2 reports. In addition, during the H1N1 outbreak, the Public Health Agency of Canada spent $322 million on communications and advertising alone. In contrast, your government's total commitment to fight the opioid crisis is $123.5 million, and that's spread over 5 years. So, Minister, my question is this, given the longer, more entrenched and more serious death toll of the opioid overdose crisis, why has your government's response been so substantially less than what was done for the H1N1 health crisis?
Well, thank you very much, Mr. Davies, for the question. We've had an opportunity to discuss this, I guess, one-on-one, and I'm happy that you bring up the question again today. We also have to recognize that the issue of the opioid crisis, as I've indicated in my earlier remarks, are quite devastating when we look at the numbers that are coming in right now. And again, with the report that came out from Ontario, it's very alarming to see the numbers that are coming up. But I have to say that our government certainly has taken bold steps so far in order to address the situation. And when we formed government, one of the first bills that was brought forward was Bill C-37, and a bill that really streamlined the application process to make sure that individuals had access to supervised consumption sites. And we recognize that that saves lives. Also with the issue of naloxone, we know that making sure that naloxone was a non-prescription type of medication that was available for people, that also saves lives. When we look at the information or the funding, that was given to provinces and territories when they told us that they were dealing with a targeted situation in their provinces, again, a specific funding was given to them. If we look at British Columbia, your province, they received additional $10 million with respect to targeted funding, and also with respect to Alberta, they received some additional funding. Just last week or last month, when I was in Calgary as well, we've made some announcements. When we look at the Canadian substance use strategy that was put in place, we've also made some investments there as well to look at the issue. And again, when it comes to services that are on the ground, it's truly important to make sure that we continue to work with provinces and territories. The federal government absolutely has a role to play, and we certainly cannot be complacent when it comes to this crisis.
No, absolutely not.
It is absolutely, for me, as I say, as health minister, my number one priority. And when I say this situation keeps me up at night,
it does.
It really
does.
does.
Well, Minister, the question was on how I was asking you to contrast why the federal government spent triple the amount of money on H1N1 than today, and I didn't hear an answer to that. But I'm going to move to medicinal cannabis. My colleague brought this up. From a health perspective, we know that medicinal cannabis is not zero rated, so already medicinal cannabis users have to pay GST and HST. We know that most prescription plans in this country don't cover medicinal cannabis, so already men and women who are struggling already have to pay extra money for medicinal cannabis. Ironically, opioids are covered by most plans and are zero tax rated exempt. So ironically, patients are incentivized to pursue a riskier option, and that's even compounded by the fact that studies are now showing that medicinal cannabis is proving very effective at helping people wean themselves off of opioids. So it's clearly a flawed policy to make medicinal cannabis more expensive than opioids. So I'm just wondering if at the cabinet table, Minister, would you advocate from a health perspective to at least treat medicinal cannabis the same as opioids?
Well, again, as indicated, the previous speaker, and I forget your name, and I don't have my glasses, so my apologies, as indicated, with respect to tax policy, again, the Minister of Finance, that's absolutely his area and the work that he's doing. And again, as indicated, next week, the Finance Minister will be meeting with his territorial and provincial counterparts, and I am certain that that issue is going to be coming up. And again, if the Finance Minister, I don't know if he ever appears before the Health Committee, but if he does, it would certainly be, a question to be asked there.
Okay, I want, again, now we know that the federal government covers the cost of medicinal cannabis for over 3,000 Canadian veterans. We heard testimony at this committee on September 14th from the Regional Director of First Nations, Chief Isidore Day here, that the government does not cover the cost of medicinal cannabis for Indigenous patients at all. Can you explain that discriminatory policy to me?
To be very frank, that is Minister Philpott's department has been working with that, but perhaps that I could ask my Deputy Minister to perhaps address that a bit.
You know, Minister, if I may, I just want to direct my questions to you because I think we'll have the staff staying after and we can follow up then, but we only have you, I think, for an hour, so I'll just defer that if that's okay.
Absolutely.
I want to move to prescription drugs. I want to read you a passage. Prescription drugs. Our current system provides full coverage for institutional care, including all drugs administered during a hospital stay. Once patients go home, however, they are not guaranteed public coverage for medically necessary drugs. Although some public coverage is provided for specific groups and situations, prescription drugs have yet to be fully incorporated into provincial health insurance schemes. Many Canadians have limited drug coverage through their employers, but a full 12% of Canadians have no coverage at all for prescription drugs. This situation is plainly inconsistent with the values upon which Canadian Medicare is based. It is both unfair and illogical to guarantee access to medical diagnosis but not to the associated treatment. Neither does it make economic sense. Those who cannot afford to fill their prescriptions tend only to get sicker and require more costly treatment later from the public system. Public coverage of medically necessary prescription drugs, as recommended by the National Forum on Health, would not only ensure universal access to treatment, it would also reduce the amount of money that Canadians are already spending on drugs.
We need a question.
I'll get to that, Mr. Chair. These advantages include simplified administration, volume discounts for bulk purchasing, and improved monitoring of best practices for prescribing. A new Liberal government will pursue a strategy together with representatives of provincial and territorial governments, health service providers, private payers, employers and unions, and consumers to address the fact that drugs have become an essential component of health care. We will develop with these groups a timetable and fiscal framework for the implementation of universal public coverage for medically necessary prescription drugs. Minister, I'm reading to you from the Liberal platform in 1997, promised by Jean Chrétien. Now, we've heard the PBO report has already shown we can cover every Canadian and save $4 billion a year. I introduced a motion in the House of Commons asking your government to start discussions with the provinces in the next 12 months, and you called that proposal premature. Can you explain to me why, after 20 years of promising federal national pharmacare, can you tell us what you're waiting for, Minister?
Well,
Just
first of all,
very briefly, because we're way over the time for the questions, so if you could just give us a quick answer.
thank you. I'll try to do it as quick as I can. How's that? If you've read my mandate letter, and I'm assuming on the Health Committee that probably most members have read my mandate letter, I'm going to quote, "Work with provinces and territories to improve access to necessary prescription medication. This will include joining with provincial and territorial governments to negotiate common drug prices, reducing the cost Canadian governments pay for these drugs, making them more affordable for Canadians, and exploring the need for a national formulary." Again, as indicated when I had the opportunity and the privilege to meet with the Ministers of Health for the first Ministers' meeting, we were able to come up with a consensus that we all want to work on improving access to affordable medication for all Canadians. And again, when we look at enhancing our healthcare system, we certainly want to make sure that enhancing the affordability, the accessibility, and the appropriate use of prescription is absolutely mentioned in that. So thank you.
That's all we can handle. Okay, now we're going to go to Ms. Sidhu, and I understand you're going to split your time with Ms. Ludwig. Thanks.
Yes. Thank you, Minister, to being here today. Earlier this week, your officials were here, and we talked about food guide, and we are working on a healthy eating strategy. This is a very important issue. I wondered if you could tell us today about the healthy eating strategy, how we can improve the health of Canadians. Obesity rate is getting high, and how we can decrease obesity rate, especially in our youth.
Well, thank you so much for the question. Another portfolio that I became quickly briefed on and versed on is our healthy eating strategy. As probably many of you are aware, last year the previous Minister of Health, Minister Philpott, launched the healthy eating strategy. And certainly some progress has already been made with respect to work that needs to be done. But when I look at the healthy eating strategy, I really look at three pillars of three areas that work needs to be done on. The first one is the Canada Food Guide, which I believe is the one that you guys are studying right now. The other one is marketing to kids. And the third one would be front of pack labeling. We recognize that as Canadians, we are facing an obesity crisis, really and truly. 1 in 3 children are either overweight or obese. 2 out of 3 Canadians are either overweight or obese. And we certainly recognize that what we eat certainly contributes to the chronic health crisis as well that we're faced with, or the level of chronic health diseases in our country. We also recognize that as a government, we're spending over $26.7 billion a year when it comes to chronic health conditions in this country. So work needs to be done. So with respect to our healthy eating strategy, we recognize that it's not the only situation or the only avenue that will help address, this health crisis, but it's certainly a step in the right direction. So when we look at the issue of the Canada Food Guide, I'm really excited to see the review that is underway right now, and I'm actually really looking forward to the results of your study that you guys are doing as well. We recognize that the Canada Food Guide is a bit dated now, but it's certainly a document that many Canadians use because it's the second most requested document, they tell me, from Canadians. So we certainly know that people still, feel the value of having the Canada Food Guide. But what I would say is that we certainly have to make sure that our food guide is modernized and up to date. We live in a multicultural country right now, and there's many different diets out there. So it's really important to make sure that the research is done. And for the Canada Food Guide, I really see it as a model to be able to tell Canadians not what to eat, but the types of things that they can eat to get the nutrients that they need. And at the end of the day, that's really, the new version of the food guide, kind of what that's going to be all about. So with respect to the food guide, that's really the work that's being done there. And I'm very pleased that the department, hopefully by mid-2018, will be able to see an update as to where we're at there.
My next question is, Canada has a large population of seniors with varying health needs. I'm happy with our investment made into the home care across Canada. Could you tell me what impact this has and how else we are helping support the health of seniors across Canada? What steps we are taking to improve health of the seniors? Like, are we taking any more steps for innovative health system, or can you tell me about that?
Well, we've heard loud and clear when negotiations were underway last year when it came to the health transfer payments, that when it came once again to seniors, long-term care services, mental health, palliative care, there's certainly areas that Canadians are absolutely concerned about, and it's a priority of theirs. So we were pleased to be able to provide some funding with respect to providing home support care services to provinces and territories to allow them to really develop services and models that work best in their provinces and territories. We certainly don't want to have a top-down approach and tell them what to do, but if we could provide them with funding, and then from there they can, put in place what best meets their needs in that area. So we also recognize that seniors want to live longer in their homes, and we really have to make sure that, again, the appropriate services are put there. Many of those responsibilities fall under the provinces and the territories, but again, by providing additional funding for healthcare transfers, it can certainly help them and help the provinces and territories take the steps that they need to effectively deal with the growing aging population that we have.
Okay, we now go to Ms. Ludwig.
Thank you. Thank you, Madam Minister, for being here today. I actually have two questions. I'll get them to you up front. The first one is on, again, following my colleague on healthy eating. I'm wondering how much funding will be devoted to the public awareness and education regarding the healthy eating strategy on an annual basis. And the second one, again, is actually about Lyme disease. I was truly surprised this summer when after the federal government and the province of New Brunswick partnered on the surveillance program, how little amount of money it actually took to get the results they did regarding, identifying broader endemic areas. But I'm wondering if you could also please describe the activities and incentives Public Health Canada intends to undertake to raise public awareness and support education regarding Lyme disease, particularly in endemic areas. So those are my two questions. Thank you.
Great. Thank you very much, Ms. Ludwig. With respect to the area of public education, with respect to our healthy eating strategy, no specific amount has been identified yet, but I can tell you through the many consultations that I've had with many of my caucus colleagues from all parties, actually not just caucus, but just members of Parliament, and also hearing from many Canadians. We certainly know that providing tools for Canadians to make sure that they can make informed decisions is very important, but we've also heard as well that the education component as well is very important. So that is certainly something that we are prepared to look into in order, to, when we look at our rollout of the strategy, to make sure that, some services are put in place there. With respect to the issue of Lyme disease, as I know that that's a passionate area of yours, I may ask Dr. Tam to provide a bit of an update as to where we're at with respect to the surveillance results.
Yes, so thank you very much for this question. Public awareness and detection of Lyme disease is a really important aspect of the federal framework. And as you've said, it may not cost very much, but you can actually do quite a bit in looking for positive ticks, for example, in the community, and partnering with different organizations, whether they be Parks Canada, whether they be family physicians on the front line, and also patient groups. There's been actually some very good examples. You've just cited one of them where partnerships really worked. In Ontario and Manitoba, Lyme patient groups said that it's worked really well for them, how they've been engaged to increase public awareness of this growing issue. From the Public Health Agency, we've been doing enhanced surveillance activities and also projections in climate data. So we can actually see where the frontiers of Lyme disease is pushing into incurring different areas of Canada. So I believe that with this further some funding support, we'll continue to improve on awareness campaigns.
Okay, time's up. So now we're going to go to a 5-minute round, and I have to say we're a little long-winded today, so if everybody could tighten up their questions and tighten up the answers, we'll all get another kick at the questions, but we've all been over, so I think...
Mr. Chair, I have a point of order on that. Mr. Chair,
going to take up the time of the minister. You know,
well,
you're taking it from everybody.
So be it, Mr. Chair. I have a point of order. Mm-hmm. You interrupted my question 3 times when I was in my 7-minute time period, Mr. Chair. Now, you have every right to tell me when I'm out of time, and you have every right to tell me that I'm nearing the end. But with respect, you have no right to try to censor me or cut off my preamble. I can use my 7 minutes any way I like. I can speak for 7 minutes if I want to, and it is not for you to determine the length of any of our preambles or the timing of our question. And it's a violation of my privilege as a parliamentarian and as a member of this committee. So with respect, Mr. Chair, we have 5 minutes, and you can ruthlessly cut us off at 5 minutes if that's your choice, although I would expect that you be consistent with everybody. But with respect, you cannot interrupt within the body of our time and tell one of our members to ask a question at a certain point because you think the preamble is going on too long.
So you went 9 minutes and 15 seconds on a 7-minute question.
Pardon me?
You went 9 minutes and 15 seconds on a 7-minute question, and the preamble was, I just asked you to submit your question, but you were way over. When I raised the issue, you were a minute over. And you made a point of saying that the minister's only here for an hour, and we should all get our questions in. But you're taking up time now, and you took much more time than you're allowed.
Well, Mr. Chair, then you should have told me I was out of time.
I did tell you to put your question.
No, you didn't. Well, that's not the same thing. I thought I was within my 7-minute time period, and you were urging me to get to my question. So all I want to make clear, Mr. Chair, is that we all have our time period, and we should have our ability within that time period to put whatever preamble we want. That's all I want to make clear with the committee.
You were far beyond your time period, but let's carry on so we can have. The minister has to go at 4:30, and we've wasted enough time. So, Ms. Gladue, 5 minutes.
Thank you, Chair. I'll be right to the second. And thank you, Minister and staff, for being here today. In Budget 2016, there was $3 billion announced for home care. And in 2017, that was expanded to be $11 billion for home care, palliative care, and mental health care. And so my question for the Minister is, can you tell me how much of that money has actually been spent and give some examples of where it has gone, especially the palliative care part?
I am going to have to defer that actually to my staff, so my apologies. But Simon, would you be able to take that?
I'm not sure, Minister, if I have the specific breakdown here. What I can say is that the $11 billion is over a 10-year period. The first-year payments have all been made to all jurisdictions. That was done in the one of the 2 budget implementation acts. We're now in the final strokes of negotiating agreements to transfer the next tranche of money to every jurisdiction, and we're actually hopeful to have some of those signed before the end of the year. And the objective is to have all those signed before the end of March so that we actually can start flowing the payments for the second year as of April 1st, which is a new fiscal year. So I can provide the details of the first year of money to the committee. They may be in my book, but I have to find them, so I don't want to take up more time.
That's okay. You can send it to us. That would be great. My second question is about the remaining thalidomide victims. There's not very many, but there are a number whose cases are outstanding. And if I know that I've talked to the Minister about this before, if you could just give an update on when we plan to have those resolved.
So thanks so much, Ms. Gladue, for the question. As you're aware, or you may or may not be aware, but last week I had the opportunity of meeting with one of the thalidomide survivors, actually, while she was in Ottawa. And it certainly, again, provided me a good opportunity to hear kind of her situation, and also the struggles that many survivors have to live with on a daily basis. The time that I spent with Ms. Sampson was very precious to me because she certainly shared with me her perspective and also shared with me, some of the needs that they have as well. So with respect to that, as you're aware as well, I'm sure that the Thalidomide Survivor Contribution Program is helping 122 Canadians at this point in time. And out of the 122 Canadians, 25 of those Canadians have been identified using the objective review process. So that was a step in the right direction. So I recognize as well that the committee has put in place recommendations because you've studied this at the committee level. And once again, I'm looking forward, to reviewing those recommendations. And also when I met with Ms. Sampson, I indicated to her as well, that I personally want to look into this matter to see exactly, what else can be done in order to effectively help individuals.
And another issue I wanted to bring forward was one about there was a tainted blood payout a number of years ago. The case was settled, and it came to my attention through some of the stakeholders that there's $65 million outstanding in the claim payments that are due to the people that were the successful claimants. So I didn't know if that was on your radar screen, so I thought I'd just put it out there. If you know anything, let me know, and if you don't, then check it out and see what can be done.
I can check it out, but do you want I can ask my officials as well. Are you aware?
Yes, I'm aware of that. So yes, there are two different settlements that were reached with regard to the blood issue, and one of the two settlements, there is a question as to whether there is sufficiency in this is a kind of simple explanation, sufficiency in the funding. And I think some of the debate has been whether or not there can be a transfer from one of the funds to the other. I think the simple explanation is that these are independent settlements that are governed by the courts, and there's no legal authority. These are settlements that were made 20 years ago that actually are kind of governed by a court process. And they're actually separate, so there's no way to kind of move money from one to the other. But I know that's been an issue that's been raised previously.
Very good. Yeah, it would be nice to get that resolved for the claimants. Now, with respect to the opioid crisis, I saw the numbers as well today showing a 68% increase in the opioid deaths in Ontario, and we know that BC was on the front lines of this, and 16 Canadians a day are dying for this. And I heard about the amount of money that the federal government is putting forward, the $6.2 million, and then some of the payments that went to the different provinces. But when I compare that to the $500 million that the government is spending to legalize marijuana, it just seems like perhaps those two are not in balance. And so if the minister could describe what are the actions being taken in the opioid crisis to prevent the drugs from coming into the country, to prevent the overprescription of drugs, to make sure our first responders are well protected, and to invest in treatment to get people off drugs ultimately.
Thank you very much once again, Ms. Gladue, for the question. When we look at the situation that we're facing right now, it's absolutely, and as indicated, we are certainly faced with a public health crisis when it comes to the situation. And again, when I heard the numbers this morning, it's devastating to see the amounts of lives lost in this situation. With respect to the actions that our government has taken, we cannot minimize the actions that our government has taken to date with respect to regulatory changes and also the issue of Bill C-37. Once again, providing access to individuals to supervised consumption sites saves lives. We know that. Also, ensuring that naloxone products are readily available to individuals as well saves lives. Also, with respect to the changes that have been made with respect to providing provinces and territories with the opportunity to open overdose prevention sites. That was an announcement that I made, I believe, about 2 weeks ago, because when we met with the health ministers' meetings back in October, some provinces had indicated that they thought that it would be appropriate if the provinces had more powers. And again, I mean, they're closer to their constituents and they know what's going on the ground. So we took that back, and just 2 weeks ago, we indicated that we were prepared to look at providing class exemptions to provinces if they choose that they want to open overdose prevention sites. The difference between an overdose prevention site and a supervised consumption site, because sometimes we talk about these terms and people aren't aware of the difference. The supervised consumption site, when they choose to apply, the municipality or the area will get in touch with Health Canada, and then from there the licensing will go through that department. It can take a bit more time. When it comes to overdose prevention sites, however, we can certainly go through those requests in a very timely fashion. And just today, Minister Hoskins got in touch with us yesterday, and we were able to approve a class exemption. So then from there, the province of Ontario will be able, to determine what services need to be put on the ground in order to provide services to the individuals in their community. And at the end of the day...
We have to move along.
Okay.
Okay, Mr. McKinnon, 5 minutes.
Thank you, Chair. There have been media reports that law enforcement is still unaware of the Good Samaritan Drug Overdose Act, which became law in the spring. And they've charged people with possession by accident only to have the charges reversed. And everyone who assiduously hung on every word of my member statement earlier in the House will know that today Canada HIV/AIDS Legal Network and the Waterloo Region Crime Prevention Council released a wallet card and fact sheet funded by the Ontario Foundation of Law. And this information will be provided to people who use drugs, service providers and volunteer organizations serving people at risk of experiencing or witnessing an overdose emergency, and stakeholders in health, social services, government, and law enforcement across Ontario. So, Minister, can you explain what efforts Health Canada is undertaking to promote the provisions of the Good Samaritan Drug Overdose Act more broadly across Canada so that drug users and law enforcement are well informed?
Thank you so much, Minister MP McKinnon, Mr. McKinnon. I have to first of all congratulate you on bringing this bill forward. If my memory serves me well, we had unanimous consent. It passed, flying colors. So we certainly recognize that there's a need, and job well done. I also have to say that earlier on in the year, I was in Kelowna, British Columbia, and I was visiting my first supervised consumption site. And as I was there speaking to the nurses, what do I see is a poster that talks about exactly your bill. So we see that the word is getting out there, and we certainly need to make more efforts to ensure that Canadians are aware of this legislation. So to answer your question, I can say that Health Canada is working with partners, including law enforcement officers, to inform Canadians, not just law enforcement officers, but also work to inform Canadians of this new legislation. And also we've done so by using social media, public spaces, and also web content. So we certainly want to continue the work because it's a really important piece of legislation. And as you've indicated, we truly want to make sure that there's no barriers for people to call 911 if it's about saving a life here. So at the end of the day, we will continue to make sure that our frontline service providers, but not only them, also Canadians at large, are aware of the regulations.
Thank you, Minister. So I'll move on a little bit, stay in the area of drugs. So Health Canada, the Canadian Institutes of Health Research, and the Public Health Agency of Canada are requesting approximately $11.8 million in Sup B to support the Canadian Drugs and Substances Strategy, which will support harm reduction activities, public education, expansion of drug science, monitoring activities, and research. Can you explain why there is a need to expand drug science and how it will be expanded as a result of these funds?
Sure, absolutely. I'm very pleased to take this question. Again, having been in Alberta not that long ago, we were able to meet with many individuals that, especially individuals with lived experience. And we were able to meet with them, and they shared with us, again, their personal stories, the challenges, but also what worked and what didn't work for them. So with respect to the investments that we're making in health research, we really want to look at pilot projects or pilot programs that are happening on the ground, and again, from there to find out what are the best practices. And then from there, if we can learn from those best practices, we may be able to adapt them in other parts of the country. But it's truly important to ensure that we get the data, because if we don't have a scope of the situation, we're certainly not going to be able to effectively deal with it. So investing in research is paramount, and it's certainly a priority of our government.
Okay, thank you. I guess carrying on in that, what proportion of these funds will be made available under the Canadian Drugs and Substances Strategy to support increased availability of treatment options?
For the strategy itself, $100 million has been earmarked for the strategy. With respect to the actual breakdown, I may defer that to Mr. Kennedy.
Sure. The additional funding coming in this year for the Drugs and Substances Strategy, we have a program called the Substance Use and Addictions Program, which has funding of around, I think it's $28 million a year. There's additional funding that comes in over the next number of years as part of the strategy to top up that program. The additional funding on top of the existing dollars, which are permanent this year, are $2 million, another $2 million next year, and then ongoing an additional $3 million. So that's extra money through that program we'll be putting out for piloting innovative treatment projects, that sort of thing.
Great. Thank you.
Okay, time's up. Okay, now is it? Are the minister good for another round of questions?
I've been just told that I've got another. Yeah.
All right. Well, you were to be here till 4:30. That was our understanding. So it is 4:30.
If I receive another invitation, I'm more than happy to come again.
All right.
Okay.
Well, thanks very much for coming.
Thank you.
Appreciated your answers. Okay, now we'll go to Mr. Van Kesteren.
Well, thank you, Chair, and I'm sorry to see the minister go because I had some really important questions for her. I wanted to talk about S5 and the plain packaging, and anybody that has seen the new packaging that's being proposed, I sometimes wonder who would want to smoke when they see those things. And it's a great approach. I think it's been effective. I think we have done a great job as a society to reduce the harm in smoking. So in light of that, I'm wondering if the government, if Health Canada is going to do the same thing with the marijuana packaging. One of your own Health Canada reports states quite emphatically that no one under the age of 25 should use this product. So would that be part of the new packaging that we will be seeing when the marijuana is put out for public sale on July the 1st, 2018?
So I think, Mr. Chair, this is one of the areas where we're actually out right now for consultation. We have a fairly detailed regulatory consultation paper that we put out for discussion about 2 weeks ago, I think, and the consultations will proceed until late January. And so there's a lot of detail in there about what the government has suggested as the restrictions that would be placed on marketing and advertising. I think what I could say generally is that the intention and the scheme that's laid out in the proposed paper is to take a fairly strict approach to marketing and branding and so on with cannabis. And certainly as regards young people who are not of legal age to consume it, there would be extraordinarily strict provisions. So the details are in the paper, and at this point, obviously we haven't gone out with final regulations, but that's part of what we're talking to Canadians and the industry and others about.
Will some of that packaging warn about driving once somebody has smoked marijuana?
I think I don't want to get out in front of the government, but the intention is to have appropriate warning labeling, if you like, health information and so on that would be a requirement that would accompany the sales of these products. So again, there's going to have to be consultation, sir, before that's finalized, but the idea would be to make available those kinds of warning messages as part of the packaging.
Will there be a direct effort to get this out of the hands of teenagers or younger people? Because that same report that came from Health Canada states that the younger the smoker is, the more likely they are to become addicted to it. Will that be part of the packaging as well, too?
I think the general intent of the regulatory scheme and the work that certainly Health Canada is doing in partnership with other departments to get ready for the legalization of cannabis, all of this is being undertaken with a public health approach in mind. Our organization is certainly well aware of and seized with the research around the potentially deleterious effects on young people. And I think if you take tobacco as a good example, there has been very good success over the last 20 years through a strict regulatory approach of actually driving down usage rates quite substantially, to the point actually where you actually see with young people there are instances where the usage rates of things like cannabis are actually now higher than the usage rates of tobacco. So I think our hope would be, to be quite frank, is that with a very strict regulatory approach, with the kinds of restrictions that we're talking about, that it would actually render it more difficult for children and youth to get access to it, and with the objective of driving down usage rates.
Will you disallow cannabis marketers to target younger users, as has been done, and rightfully so with cigarettes as well too? Will that be part of your focus as well too?
I think it might be prudent if I could offer the committee that we could write and provide a more detailed kind of response to your questions, and it's not to kind of dodge the question, but I think it almost merits a more detailed response than I feel competent to give. I think what I could say, sir, is that absolutely the very clear objective here is to strictly, kind of prohibit and avoid directing this kind of stuff at people who are not of legal age. So where a province has fixed an age, 19, 18, where that age has been fixed by law by a provincial jurisdiction, below that there would be very strict prohibitions and efforts made to ensure that that product does not make it into the hands of those young people. But I think it needs to have and it might be useful to come back with a little bit more verbiage than I could give in this discussion.
You're very strict with me, Mr.
Well,
Chair.
no, you're beyond, but not as far as some others. So now we'll go to Mr. Oliver.
Thank you very much. First question is around health research and whether we are making adequate investments in health research and support to CIHR. We've heard from virtually every study that we've done that research is required, whether it was on antimicrobials, how important it was because the pharma companies were not investing in that. There had to be investments made for antimicrobial research. The cannabis bill, we heard about the need for research now around cannabis, the health effects, the longer-term consequences of it. The opioid study, we heard from virtually every person in that there was a need for treatment and research into treatment protocols and directions. And yet I didn't see, I guess, where do you sit on research, Mr. Kennedy and Mr. Perron? Do you feel CIHR is adequately funded? I have to say that the majority of groups that come and see me do not feel there are sufficient funds through CIHR and the other granting bodies to cover the degree of research that's needed.
Thank you, Mr. Oliver, for the question. Clearly, as regards the supplementary estimates for which this committee is examining, we were delighted to receive an additional $5 million that have gone to some of the items that you indicated. One is the funding, and as the deputy referred to earlier, for the Canadian Drugs and Substance Strategy, which is very much to address many of the issues specific to the opioid crisis. And this is in addition to our annual grant funding level of approximately $1.1 billion in available authorities. This is a significant amount of money that we try to invest as wisely as possible, given the very significant expectations and pressure on health research generally. In the area of antimicrobial resistance that you referred to, for instance, in the past 5 years, we've spent well over $100 million in AMR research, an average of $22 million a year. We work very closely with the Public Health Agency and the like. As regards to opioids, if I may, Mr. Chair, just indicate that many of the investments recently, whether they be through the Canada Drug Strategy or our funding more generally, is to provide clear evidence of what works best in what setting, and to provide the direct kind of clinical guidance required for clinicians and first-line providers to ensure that those efforts are well done. For instance, there is a study underway right now to evaluate models of care. Is it methadone or buprenorphine and the like?
I understand some research has been done. So correct me if I'm wrong here, but I think the overall transfer to CIHR is about $1 billion, and you had a $5 million increase. Is that about right?
Correct. It's $1.1 billion annually, with a $5.5 million increase for this.
It's interesting because we heard from one of the researchers from McMaster that after he had made a discovery of a new possible antimicrobial agent in some fungus from some soil from Nova Scotia, that they couldn't actually they needed $600,000 to bring it to market, and they couldn't do it because they weren't able in 2014 or so to secure funding. And most of his grad students, or I think he said all, are leaving for the U.S. So I'm worried we're losing our research, but more importantly, we're losing our capacity, our next generation of researchers, because we don't have adequate funding. Do you have a sense of what's needed as an investment into CIHR to regain our leadership role in health research in Canada?
Well, specifically to the matter that's raised, I can just underscore the importance of early career investigators and the pipeline of researchers. That is a very significant area of attention for ourselves, which we've directed an additional $20 million a year specifically to ensure that those young investigators have a chance to get into the health research system and go forward. As members here may well know, there was a fundamental science review undertaken that was tabled with Minister Duncan, and for which Minister Petitpas-Taylor and Duncan commented on recently in terms of some improvements to the coordination of the tri-agencies, that being CIHR, NSERC, SSHRC, and the Canada Foundation for Innovation. We know that the amounts tabled in that report are very significant and underscored by a number of fairly in-depth analysis that we know the government is examining now, and we'll wait for further information as that unfolds. Thank you.
And just a really quick question to Mr. Kennedy. So in the minister's new mandate letter, there is a requirement that she review the need for a national formulary. Where do you stand on the issue of the requirement of a national formulary, and how would you undertake that review?
We're doing work with the provinces and territories now to look at issues around a drug formulary. This is obviously a kind of a big policy question that all governments have to grapple with, so I can only speak as an official about some of the possible efficiencies. But certainly there are a number of aspects to a formulary. One of them is what drugs are on the formulary, but almost more importantly is what is the conditions of access. You know, what conditions are actually authorized by the province or territory for access to the drug. So in the work we've done, one of the things that we discovered that's actually quite complicated, if you like, is it's not just a matter of comparing, kind of what drugs are available in each jurisdiction, but it's like under what circumstances will the payments be made. If we could advance that kind of work and start to have greater harmonization of the drugs available and the manner in which they're used, the kind of conditions of access, it starts to make it a lot easier to have joint negotiations, to kind of move forward in a common way to procure these kinds of products. So there's a lot to recommend work with the provinces and territories to try to have a more harmonized approach, I would say, might be a way to respond.
Time's up. Okay, Mr. Davies, 3 minutes.
I'll try some short snappers. Okay. Quick answers if I could. The mandate letter mandated the minister right from the beginning of this government to reduce drug costs for Canadians. My question is, have drug costs for Canadians come down?
I think what I would say to that is that there is a very ambitious agenda that we feel there is very good analytical evidence to suggest that once the measures that have been proposed are in place, and we just had draft regulations gazetted for the Patent and Medicine Prices Review Board, for example, they will lead to meaningful reductions in drug prices.
Mr. Kennedy, so I'm going to be short snapper. So they haven't come down yet. Would that be a fair comment for me to say?
I think what would be fair would be to say developing the changes to the way in which drug pricing is managed in this country and the way in which purchasing and all the various machinery that's actually involved in the pharmaceutical system, that's a significant undertaking, and we're sort of well underway, but it's going to take some time to see the impacts.
Okay, I'll try it a third time. Have drug costs come down today as where they were 2 years ago for Canadians?
Drug costs have certainly come down in a variety of areas. I have my own experience, for example, at Health Canada, where we manage a fairly large drug plan for First Nations and Inuit. And I can tell you, very forthrightly that our joining of the Pan-Canadian Pharmaceutical Alliance has actually led to meaningful reductions in the prices we pay for some of the pharmaceuticals by virtue of the work we're doing with the provinces and territories.
Now, on Indigenous health, the Prime Minister has famously said it's the most important relationship to him. The state of health among Indigenous people in Canada, I think we can all agree, is greatly concerning. In response to Report 4 of the 2015 Spring Report of the Auditor General on access to health services for remote First Nations communities, Health Canada pledged to conduct a comparative analysis of access to health services in remote First Nations communities and non-Indigenous remote communities. Health Canada set a deadline of summer 2016, but we learned last spring at Main Estimates that this report was never in fact written. Why wasn't that report written?
I'm sorry, I'll have to maybe defer that. No, I think that's a question that would be better directed actually to the Ministry of Indigenous Services. I mean, by order
well, it was Health Canada.
Yes, but by order in council now, the responsibility for First Nations and Inuit Health Branch is actually no longer the responsibility of Health Canada, and I'm no longer the deputy head responsible for the organization.
Okay.
I mean, I'd be answering for a colleague.
If at time on S5, we know every day we wait on plain packaging and tobacco, young Canadians start smoking, get hooked, and will die every single day. Why is S5 languishing on the order paper? Why aren't we moving forward with S5 when every day counts?
Well, I think that would be a question, Mr. Chair, probably better put to parliamentary officials than bureaucratic officials. But what I can say is we're doing a lot of work to get ready for the eventual deployment of regulations once the bill passes. So certainly we're not I would say I could give assurance to the member that just in terms of the parliamentary process, it's not slowing down the work in Health Canada to prepare for the eventuality of this legislation coming into place.
I'm sure I'm out of time now.
Seconds.
Is the federal government giving any direct funding to overdose prevention sites in Canada?
The funding that we would be providing would be funding that we would be providing, as the minister explained, to provinces and territories, and they in turn would be making those sorts of allocation decisions.
So no direct funding?
Not that I'm aware of, sir, no.
Okay, time's up. Thank you very much, everybody. That concludes our session. We're going to suspend for a few minutes, and we're going to go into committee business, and we have
just a point of order.
Yes.
I think it's a point of order. So I just want to reflect on the sort of boondoggle the first hour we had with the ministry in terms of timing a question. So with the questions that we have, the way they time out, and with a 10-minute introduction, we have like within 1 minute sufficient time for everybody to have their questions asked and answered, if people respect it. So I know generally as a committee, and to be fair to you, Mr. Chair, generally as a committee we're pretty relaxed on this. We often have time left over, so you're very lenient. You let people sometimes ask their questions after their time frame is up, or you let the person responding go on because they're good questions and we want to hear the answers and we're interested in. But when we have the Minister of Health here, and we have exactly 1 hour, I think it's important that you keep everybody to their exact time frame. We had one member that framed a question almost 30 seconds after their time ran out. We had another member that framed a question a minute and a half after their time ran out. We had another member that framed a question exactly as their time ran out. We were almost 15 to 18 minutes short of time. Mr. Davies' point of order was not that long. He was maybe 2 minutes on his point of order. So we really lost close to 15 minutes of committee questioning for those that didn't get on because there was 2 5-minute and a 3-minute question, a 3-minute block that didn't get up. So I'm going to ask that I think when the Minister of Health is here, or any minister is here, and we have a 1 hour time block to pose our questions, that you keep us rigorously to those time blocks. And members, if they want to make a long statement, great, but they're not going to get an answer. Their time has gone to their statement, and they can pose a question at the very end. I've been other committees now where the chair says, sorry, time's up, and there's no time to answer the question, and we move on. So I think for these important sessions where we have a minister here at the committee, we all have things we want to ask, we all have things we want to talk about, you need to keep us on our time block.
Just to answer that question, we previously discussed this, and my policy is that if there's time left for a member to ask a question, I never allow a question to be asked after the time is up. But if there's time left, I let the question be asked. Like Mr. Davies started his question within his time, but it was a long, long question, and that took a lot of extra time. But he's not the only one.
So that goes to the point. I think in these, I understand that's your practice.
And if that's, I'm at the will of the committee if they want me to, however they want me to do it. But I have found that's worked. But I agree today it didn't work. And if the minister is here and only have an hour, then I'll keep it at the time if that's the wish of the committee. And I think it's a good suggestion. We have Mr. Davies.
Well, thank you. Well, I want to somewhat apologize because what I thought, Mr. Chair, when you were interrupting was that I was still within my 7 minutes. So that's what I thought. So, and I have been on other committees when the chairs, you have never done this, but where chairs try to interfere with the questioning by directing it. I have actually had chairs say, put the question. And so I was standing up for the principle that each member of this committee can do what they wish with their time, and that's on all sides of this. I was going to say that I think you've done an excellent job in using your judgment as to and I think everybody goes over. I've been in this committee. Every single member of this committee has gone over at one time, or the witness has been allowed to go over. So you've been very fair about that. What I would say is this: is quite honestly, I think the minister should be asked to come for 2 hours next time, not 1 hour. Surely the Minister of Health has 2 hours every 6 months for the Standing Committee on Health. And I think I would rather see that happen so that members would actually have a chance to, put their questions more fulsomely to the minister. Some of my questions to the very able staff quite rightfully were deferred. Well, you should have asked that to the minister. And I would like to have the chance to put those questions to the minister. So I think next time we ask the minister to come here, rather than try to truncate 7 minutes or 3 minutes, I would rather say, let's try to ask the minister to have 2 hours. And finally, what I would say is this. I also think the practice of the minister asking her officials to answer the question when she's here is inappropriate, because we have the staff usually that stays after. Usually they stay for the second hour, and that's when we have a chance to direct our questions to the departmental staff. But we only have limited time to put our questions to the minister. And that's why if the minister doesn't want to ask or wants to defer to later, that's her prerogative. But to have our time taken up with the minister deferring to the ministerial staff takes your 5 minutes or 7 minutes and makes it even less. So that would be, that would be my suggestions.
The last thing the minister said was she'd be glad to come back anytime. So but when we do invite her back, we can ask her to come back when she can have 2 hours, if that's the wish of the committee. Ms. Gladue.
Thank you, Chair. And on that same point of order, I wanted to say that I enjoy your usual collegial latitude with respect to the way we answer questions. And I would just provide some sage wisdom, which I gained on the Status of Women Committee. I found that over time, the more latitude that was provided, the more likely it was that people were going to ask a question with 0 seconds left to go so that they could then hear the answer. And sometimes we began to chop them off at the knees and not allow the answer if they used up all their time asking the question. So that could be a tactic that you may enjoy.
I'll take that into consideration. Mr. Oliver.
Be clear again. So the way we normally run our committee process, the latitude that you show, and you're fairly generous with people answering. Usually the people answering you're quite generous with once the question's put. And I think that's fine for our general, but when we have a time-limited window with a very important, our main minister, then I do think the rigor of holding answers and questions to it. With respect to Mr. D, I think most ministers generally come to committee for an hour. I don't know. I think that's generally the rule. We've only had our ministers here for 1 hour. What I would like to see is a full round of questioning with the minister, and then a full round of questioning with the executive branch and the others, so that we can do one round with one and one round with the other, and I think that would be a more robust.
I found the answers long today too, not only the questions.
But you have to cut the answers.
Mr. Van Kesteren.
Thank you, Chair. And one simple solution would be, when we know we have the minister for 1 hour, just to get a consensus that we go to 5-minute rounds. I think part of the problem is the 7-minute rounds, and you do a great job. But you're absolutely right. Oftentimes, the answers get a little long, and maybe at the beginning of the meeting, then we could just remind everybody that the opening statements, whatever they are, would be followed by questions and answers, and we're trying to stay within 5 minutes, and whoever is answering the question sees the clock there as well too. So it's just cooperation between everyone. But I think if we went to 5 minutes, if we had that consensus, that would free up enough time that everybody.
We've established a set of rules, but if we're going to change them, we have to do that through a proper.
Before the meeting, yes. Yep.
Mr. Davies.
Just one point, and that is we have to recognize that there's two tangoing here. So it's not just the questioner, it's the answerer. And the thing is, if you tighten up and get strict on the time period for questioning, then what will also happen is we as questioners will tighten up on controlling the long, rambling, and sometimes completely unresponsive answering of the minister. And that also has to be noted as well. I mean, I think all of us, I know I asked several questions that the minister simply did not answer. And that's her prerogative. I mean, or maybe she decided that it was an answer she liked to give.
I don't know if you've noticed, but the witnesses we've had that answers the shortest were the RCMP and police. They are very short with their answers.
Anyway, just the facts, ma'am.
That's it. Yeah. We got the message. The chair has the message, and yes.
Just, Mr. Chair, I just wonder if you might indulge me. I found the figure that Ms. Gladue had asked for. I could read it into the record now, which would avoid me writing to the committee later, but I'll...
Fire away.
So the figure that that the government has put into home care in the current fiscal year is $200 million. The total amount for home care, mental health, and so on is $300 million. So that money ramps up over the next 10 years, but the initial amount's $200 million this year. Well, the $200 million would include palliative care, will be within the home care amount. Thank you, sir.
Okay, thank you. Okay, we're going to suspend now and go into, for a few minutes, then we'll come back and go into committee business, which we've already been in now for about 10 minutes.
So that we're done?
Reconvene. Everybody take your seats, please. We have on our committee business, we have Mr. Davies' motion. Just before you get carried away or anything, Mr. Davies, I'm going to read the motion first so everybody knows what it is. I'm going to make some comments because I've had discussions with the chair of the Indigenous Affairs Committee. And even today, we learned some things both from Mr. Kennedy and from the minister's statement. So the motion is that the Standing Committee on Health study the status of health and health care within Indigenous communities in Canada, including status, non-status, on-reserve, off-reserve, urban Indigenous populations, with the objective of better understanding the particular health care needs of this population. The gaps in service delivery, the review and the effectiveness of the First Nations and Inuit Health Branch of Health Canada, and report its findings to the House. Now, in discussions with the chair of the Indigenous Affairs Committee, they intend to do this. They've done 2 studies already on it, and that they want to continue. This is a 3rd study. And also, Mr. Kennedy just said a minute ago he wouldn't even answer a question about Indigenous health because that's all over to Indigenous health. And the minister said, in her opening statement, she said, therefore, significant funding associated with Indigenous programming included in these supplementary estimates will now fall under the purview of Minister Philpott. So it sounds like Indigenous health is moving to the Minister of Indigenous Affairs. So that's just my comment. So now, who wants to, any comment? Mr. Davies.
Well, thank you, Mr. Chair. I want to briefly review a bit of the record. On February 17th, the Chair, you were talking, I'm going to quote from the meeting on February 17th. You said, on another issue, I agree with Mr. Davies on Indigenous health. It's come up from some members in talking to me. I haven't had any direction at all from the minister, by the way. I've not had 1 ounce of direction from the minister on this, and I'm pleased that we haven't. Eventually we will have, because there will be legislation, and hopefully she'll come here and make a presentation and tell us her direction. But nobody is trying to direct this committee. We're on our own, and I hope we stay that way. I appreciate that. I did talk to the Minister of Indigenous and Northern Affairs because the Aboriginal issue had come up, and I wondered if it would be a problem for her if we did this. She said, quote, "No, I'd love you to do a study on Aboriginal health," end quote. Just to let you know, she said that to me, and I was very pleased to hear it. That was February 17th, 2016. On February 22nd, 2016, our subcommittee met, and that's where we prioritized some issues. And we came back with 5 issues, and those 5 issues included pharmacare, it included antimicrobial resistance, it included community care, and there was 1 other issue on blood supply. We've done all of them except for home care and Aboriginal health. On March 7th, this committee, 2016, adopted the subcommittee's report, formally adopting those 5 priorities. So there's no question that this committee has already adopted those priorities as we set forth. Now, the question that you raise about whether we can or should do this report, undertake this study, I think, as you've long stated and very correctly, Mr. Chair, these committees, we're masters of our own affairs. We don't take direction from anybody, not the minister, not other committees. Now, so there's nothing that prevents us. I think it's important for my colleagues to understand that whether any other committee is or is not studying something is not a barrier to us undertaking a study if we want. Now, it might be instructive. Number 2, I checked with Charlie Angus, our critic, and he told me no motion has been made before Indigenous. You said you spoke to the chair of the committee, Mr. Chair, but no my understanding, unless I'm mistaken, is no motion has been made before the Indigenous Affairs Committee to study Aboriginal health. We have an outstanding motion that has been here for quite a long time. I wanted to mention 1 or 2 other things. Mr. Oliver mentioned a couple of concerns last time. He was wondering whether or not we were duplicating what the Indigenous Affairs Committee studied up to now. I have a copy of their report, and it's Breaking Point: The Suicide Crisis in Indigenous Communities. So the focus of their report was on suicide. I think they did look at some of the social determinants for sure around that, but it was not looking at broad health indicators of Indigenous people in this country at all. And the second concern was whether or not the federal government has jurisdiction over Indigenous people when they're not on reserve. And I could find the actual information, but my understanding and information is that absolutely the federal government retains jurisdiction over Indigenous Canadians wherever they are in the country. So I don't think those are barriers. So that the final question remains, should we do it? I think I mentioned last time the average life expectancy of First Nations people in Canada is 5 to 7 years below the Canadian average. Now, that is the number 1 health indicator, life. Number 2, the rates of tuberculosis are 37 times the national average. We know, and in terms of mental health issues, suicide, 5 times higher suicide rate among Indigenous people, and we know that there's chronic problems with diabetes, with obesity, and with a range of health issues that arise from living in poor housing and not having access to clean water. The Prime Minister has said that no relationship is more important to this government than that of First Nations. And I would like to take him at his word on that. So I think that as a health committee, if we're looking at studying health in this country, then if we don't start with the single largest group with the single biggest challenges facing their health and start to tackle, broadly speaking, what are the causes of this? What's the real experience that they're having? What recommendations can we make to the government to address them as the health committee? Then, I would respectfully suggest that is the #1 priority of us as a health committee, and we have many, many important issues that come up. As I said last time, this committee has done zero travel. We have not left Ottawa. And I don't think you can understand real healthcare problems in this country without actually getting into communities and experiencing it a bit. And particularly that's the case in First Nations communities. Just last meeting, we had representatives of the health department tell us that the oral health of First Nations is, well, quite honestly, it's appalling. We know that studies were ordered to be done within the health department that looked at comparing services Indigenous people have in remote communities versus other non-Indigenous communities and remote communities. Wasn't done. And I was really disturbed to see a report today of a young woman who committed suicide in Attawapiskat. She was 13 years old. And leaving aside the suicide and mental health component of it, when you read the story of this young woman, this young girl, it's an absolute microcosm of everything wrong with the healthcare system and Indigenous people in this country. She lived in a house with 20 people. There was a mold problem in the house and she had asthma. So it was exacerbating her asthma. The sewage system backed up. And so they were living in this house with the smell of raw sewage, which impacted her health in other ways. She was not able to access health care for her specific conditions, all of which led to a situation of despondency, depression, causing her to take her own life. And I don't think that story is uncommon. So for all those reasons, this committee's prioritization, the priority the government has given to Indigenous health, the crying need in this country to study, and even if, by the way, the Indigenous Affairs Committee does choose to study some aspects of health, I don't think that's a reason for us not to do it. I mean, perhaps we can even join in some ways. We could coordinate our services because it's such a broad area that neither committee is going to be able to cover everything in health. And I'm sure the Indigenous Affairs Committee will be looking at other things, perhaps the legal structure, perhaps constitutional issues, perhaps provincial, federal, like they could be looking at other areas that are specifically of interest to the Indigenous Affairs Committee that we wouldn't be looking at as a health committee. So I'm going to ask my colleagues to support my motion that you've already read out, basically to study Indigenous health in Canada as our next major study undertaken by this committee. Thank you, Mr. Chair.
Dr. Elson.
I agree wholeheartedly with the need for this study. I flew with Air Ambulance for 13 years, spent a lot of time going to remote northern communities. I've seen the appalling conditions that this population lives in and the state of their health and all the other services available to them. However, what exists now, which did not exist when we first brought this up in February, was there's a new ministry to deal with all of these services, all-encompassing services. From chair to chair of the committees, that committee has expressed an interest in doing that. And I'm not saying this would be a barrier to it, but it may be an unnecessary duplication of services. Should their study start, and it turns out that there's something that they are unable to do or find that it would be best suited for us to do this, then we could revisit this topic. But right now, I think given that what has been stated from the chair of the Indigenous Affairs Committee, that this is the most appropriate committee, that the Indigenous Affairs Committee is the most appropriate committee to study this.
Mr. Davies.
Now, I'm not 100% sure of this, but I'm pretty sure, and I stand to be corrected by Mr. Chair or the clerk. But the new ministry that is headed by Dr. Philpott, which is handling that part of the health aspect of the Indigenous Affairs, I don't think there's a ministry there, and I don't think there's a committee. And as far as I know, Health Canada, and maybe the analysts can help us out with this, Health Canada is still responsible for the delivery of healthcare to Indigenous people. Now, and if it's not Health Canada, where has it gone? Because I don't think there's another department. I don't think there's another parliamentary committee. So can someone help me understand that aspect?
I can't help you. First of all, I haven't talked to anybody except the co-chair, who's my seatmate. And I'm really proud of our committee that we do determine our own agenda. And nobody's talked to me, or I haven't talked to anybody other than the chair of the other committee. But, those are good questions. But I do, Mr. Kennedy just wouldn't answer a question on Indigenous healthcare because he said that's now in the Indigenous portfolio. I mean, he just did that a minute ago. He wouldn't answer the question. So I don't know. I can't answer the question.
Yeah, but it was, if I just might, Mr. Chair, it was unclear to me. First of all, one answer by a bureaucrat to one question should not be enough to derail our committee. I mean, I was unclear where that. He was deflecting a question to some other department, but I'm not quite sure. But I'm pretty sure that health care for Indigenous people in this country has not been now delegated to the Ministry of Indigenous Affairs. I know there's been a split in terms of services and, in fact, I'm not even quite sure what the split is in the government's Indigenous Affairs. But I don't think that health care has been taken away from Health Canada.
I'm with Dr. Elson on this. I do think a study should be done, whether it's us or the other committee. But here's what the minister said in her opening statement. I underlined it when she read it. She says, significant funding associated with Indigenous programming included in these supplementary estimates will now fall under the purview of Minister Philpott. So these are health dollars under the minister.
This will be my last, and I'm only finishing this. I realize there's other people to talk, but I just want to, because it's on the same point, Mr. Chair. Yes, but that may be, but Dr. Philpott is not the minister to whom the Indigenous Affairs Committee reports, I don't think, and she has no ministry or department. So it's a bit of a fuzzy area there.
Mr. McKinnon.
I was just going to comment that what I heard the minister or the deputy minister say was that an order in council had been signed, or a memorandum that did in fact transfer this over to this other new ministry. And it is my understanding that the Indigenous Affairs Committee will be responsible for well, it doesn't report to a minister, of course. The minister reports, if anything, to the committee, but it will be related to that new ministry. I'm very comfortable with what Dr. Elson said. The priorities you mentioned from back in February of 2016, I wasn't here at the time, but the terrain has shifted since then. We have a new ministry. I'm very comfortable with giving them the lead on this and seeing where they take it. I agree that it's an important study, but I will be supporting I'll be voting against the motion. So.
Seeing no other voices, we'll call a vote. Mr. Davies.
I don't want to put the analysts on the spot, but do they know? Like, can you give us some information about where the responsibility for Indigenous health falls now from a departmental point of view?
So I haven't seen anything on the government website in terms of a specific announcement, but in media reports, they did say that FNIB, the First Nations and Inuit Health Branch, has been transferred from Health Canada to the new ministry.
Okay.
Okay. All in favor of Mr. Davies' motion? Show of hands. All in favor? All opposed? Motion defeated. So with that, I'm going to conclude our meeting, unless there's other business. Seeing no, Ms. Gladue.
Well, then for our next study, I would move that we go to the next topic on the list, which is home care.
Well, we would like to move a motion.
I would like to move a motion that our next study be on home care, the next item on our list.
All right. Mr. Davies.
We should probably bring the motion up because I think it was community care and home care. So it was, the issue about delivering more services in the community setting, the transition from the acute care hospital to the community. So I believe that motion was more than just home care. It was, so I don't know if we can pull up the motion for clarity in terms of what we're voting on.
The motion was to undertake a study on home care and palliative care and to report the findings to the House.
That sounds marvelous. So moved.
All right, any debate on this motion? Dr. Ayelson.
The debate be adjourned.
Okay. All in favor of the motion of the debate be adjourned? All opposed? Motion carried. Meeting ended.